NeuroNexus. Welcome to our May webinar on NeuroNexus, Neurodivergence and Substance Use Health with Megan O'Brien. I will start with our Medify land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. Medify is located in Toronto, on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Atawendrons. This is Dish with One Spoon treaty territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Small bits of housekeeping. As we said, please post your comments and questions in the chat box at any time. Megan has kindly said that if there are questions that feel like we should use them to interrupt her because they're relevant to the moment, that I can do so. Otherwise, I will be keeping track of the questions and comments and collating them. We have about 30 minutes for a Q&A at the end of the session. There will be a session evaluation. Please complete it. It gives us really important feedback and is important for our accreditation and for your credits. A thank you once again to our 2024 webinar series committee, who helped to ensure that we had representation from different sectors and that we invited an array of presenters to meet the learning needs and interests of our Medify community. Our last webinar before the summer break will be Carol Hopkins speaking about culture as healing, and she's fantastic. So we look forward to that as well. So I'm excited to learn from Megan about neurodivergence and substance use. Megan, I'm sure, will review her own objectives, but I'm looking forward to understanding more about the relationship between neurodiversity or neurodivergence in the context of substance use, to learn more about the concepts of risk and resilience and their application for mitigating the risks of substance use, and how to develop a tiered prevention approach to substance use that acknowledges the unique needs of neurodivergent individuals. So let me introduce Megan. Megan O'Brien has a decade of service in the addictions field. She combines her expertise as a registered social worker with her personal journey as an autistic individual with ADHD. Currently, she is a provincial harm reduction consultant in Newfoundland, where she champions collaboration, intervention, and harm reduction in substance use health. Megan's approach, deeply influenced by her own neurodivergence and family experiences with addiction, focuses on fostering understanding, empathy, and supportive environments for recovery. Her work aims to dismantle stigma and highlight the nuanced interplay between neurodivergence and substance use. Megan, we're so pleased that you could join us. I will hand over to you.
Perfect. I'll just make sure I'm sharing the correct screen. So is that the correct screen here? Just to make sure. Okay.
Yeah, looks good.
Okay. Well, thank you for that wonderful introduction. So I'll just go ahead and get started. As Paula, who's here from Newfoundland, knows, I am one who can talk and talk on very simple topics forever. So this is a very important topic to me, and there's so much that can be learned in this area. So I'll do my best to kind of cover everything as best as I can. So I'll try to stay on task and stay on time. So I have no disclosures to report. So just to start with that. So obviously, Jennifer already went over a bit of a bio, but I just wanted to give, I guess, a picture of who I am and why I'm presenting on this topic today, or kind of give a backstory about why I'm talking about it or why what I'm saying should be of any importance. So as I already noted, I'm a social worker by profession. For the first 12 years of my career, I worked as a counselor. And one of the things that it really stood out to me, even in the beginning of my career when I worked in corrections, was the high prevalence of individuals who I was providing service to who had ADHD in particular. I remember meeting with, my first field instructor and saying, is ADHD something, is it the chicken or the egg? Like, do people have that before they come to see us? Is it something we give to them? Obviously in a joking context, but I really, at that time, not knowing that I was autistic, that pattern recognition, recognizing that there were so many people with ADHD and not really understanding why they were, why it was so prevalent. Also in my professional career, I do a lot of research, but also that comes from a special interest as being an autistic individual. If you give me a question, I'll find a way to answer it to the best of my ability. I've always been someone who advocates for a variety of different communities, but also in my professional career, I've served as an advisor on a few different committees, both as a social worker, but as also someone with lived experience. From a more personal perspective, I, much like other adults in today's day and age, or adult females in particular, was a late diagnosed autistic. I was diagnosed with obsessive compulsive disorder quite early, in my early teens, but the professionals that I worked with were really, really not confident in that diagnosis. They recognized that something else was probably going on, but they could never put their finger on it until really the definition or the diagnostic criteria and the understanding of it changed. Did they start to seek out other professionals to do further assessments? I was diagnosed initially with ADHD. And something interesting about the interplay of autism and ADHD, which I'll get into, but just to start out, is when I started ADHD medication, that was really when the signs and symptoms associated with autism started to show. Things that I had tried or come up with different coping strategies over the years, I just wasn't able to upkeep after starting medication. So it was the benefit of the ADHD medication, the benefits that I started to see, but also that's when autism really started to, those autistic traits really started to come through. In addition to neurodivergence and neurodiversity, I come from a family where my father and other close family members struggle with substance use disorder. How this is important is that's, a population or a group of individuals that I've been passionate about my whole life and really what brought me into the field of social work, but also an interesting or how it plays into neurodiversity and substance use is there is a strong correlation represented in the research that shows that autistic individuals, their family members, both their parents and their siblings, have a higher likelihood of living with substance use disorder. So I kind of come with the professional background of working with individuals with substance use disorder, as well as ADHD and autism, and also as a lived experience. The other thing before I move on is why I became so passionate about it is after my own diagnosis and my own understanding of neurodivergence and ADHD grew, I really felt like my ability to provide care and service to neurodivergent individuals grew exponentially. I started to see struggles that clients were experiencing that I never truly understood. And it really helped my ability to advocate or to help them advocate for themselves for appropriate care. So we've already talked a little bit about the learning objectives, but how this is going to go or how we'll go through it this evening is really like set the ground or lay the ground for what is neurodivergence, recognizing that some people might not even know what that term means. For myself, when I the first time I heard the term neurodivergent was actually from a new client that I had started seeing probably 4 or 5 years ago. And I had to acknowledge that I didn't know what that meant. And I know that was really frustrating for that client. And they expressed, you should know what that means. You're a social worker, but able to work through that together. So just really setting the ground rules of what that is, or the background of what that is, a little bit on substance use, and then a little bit on the research that is available to us that talks about the correlation. Then we'll talk a little bit about risk and resilience. So that'll be coming from a biopsychosocial perspective. As a social worker, that's always been the best way for me to kind of understand the client experience, understand how I can best, or how we can best provide support to clients. So just looking at it from both the risk and protective factors that increase the likelihood that an autistic or ADHD or really neurodivergent individual would experience issues with substance use or a substance use disorder. And then finish off with some, I guess, exploring how having a more robust knowledge, or the more that we know about the interplay between neurodivergence and substance use, how that can impact the care that we're able to provide, and how we can make changes to the care that we provide, both from a clinical perspective, but also from a prevention perspective as well. So to be able to understand neurodivergence, we really first need to be able to understand or look at the concept of neurodiversity. So neurodiversity is a concept that was first coined by an Australian sociologist by the name of Judy Singer in the early 1990s. So what Judy was looking at, and what you can see specifically from the term itself, is looking at the nervous system and the uniqueness inside, or the uniqueness that people have within their their nervous system. So it looks at brain differences and sees those as normal variations in the human body and the human experience. It doesn't just look at them, but though these differences are actually rooted in the scientific observations of the human brain. So it looks at how people have different ways of experiencing and interacting with the world in front of them, or the world they're in, and recognizes that this could be representative of both strengths, so differences that are positive in nature and strengths that should be celebrated, but also that people may experience challenges as a result of these differences in their brain and their brain functioning. Also, what it looks at is that there's really no right way of thinking or behaving, and seeking inclusive practices that accommodate rather than to conform. Because essentially the opposite of neurodiversity is really what we see in today's society is a neurotypical, meaning what we would consider the normal brain functioning, as the way of being, and that what we do for people who aren't neurotypical, so those people who are neurodivergent, is getting them to conform. So getting them to change their way of being so that they can be within a neurotypical functioning. And by doing that, we're also saying that neurodivergent individuals are experiencing some level of a deficit. So there's something that they're missing, or there's some difference within them that is wrong. Whereas neurodiversity looks at those differences as something to be celebrated, something to be highlighted, and that this is just really a normal part of the human experience. So neurodivergence in particular, so what it is in neurodiversity, there's two ends of, I guess, the spectrum. There's neurotypical, which is what we consider to be the normal functioning or normal. Then neurodivergent is those that diverge from what is considered the typical functioning. So it describes these variations within someone's neurological functioning, and that these differences result in differences in their learning, their ability to process, their ability to interpret, and also their ability to feel. And when we look at neurodivergence, it's really about embracing and understanding this diversity and shifting away from that deficit approach. So when you think about it, some of conditions that are neurodivergent, which we'll look at, such as ADHD and autism, a lot of the approaches that we've used to provide support or to provide care have really been looking at getting people to change their way of being and getting them to behave in a way or act in a way that aligns with the neurotypical, or what we consider to be normal. Also, the neurodivergence approach shifts away from a disease model. So it's not looking at, neurodivergent conditions as a disease or a disorder, but looking at them as conditions. So what that means is there's no cure, which we know to be true. There's no cure for autism. There's no cure for ADHD, but there are things that we can do to reduce the challenges that are experienced by individuals who live with these conditions, and also things that we can do to celebrate the strengths that they have. Also, just from a statistics perspective, it's estimated that about 15 to 30% of the worldwide population is living with some level of neurodivergence. However, I would argue that this percentage could be much higher. It grows on the daily, especially with the differences in diagnostic criteria and the presentations that we recognize. More and more people are being diagnosed with a neurodivergent condition. So neurodivergence is obviously more of a broad terminology, whereas neurodivergent looks at the individual in particular. So it is, I guess, the terminology for the person who's experiencing neurodivergence. They are a neurodivergent individual. And then the flip side would be neurotypical. I just like to highlight this quote because I think it really highlights neurodiversity and neurodivergence. It's powerful to realize that neurodivergence has to do with how someone's brain is structured and functioned. It's a part of variability in a human's and their life, and it makes life on Earth exciting, interesting, and beautiful. So really about celebrating those differences and not looking at them as something negative that needs to be changed, but looking at what neurodivergent people can bring to the table and having those things be celebrated. When we look at neurodivergence or neurodivergent, there is what we would call the neurodivergent umbrella. So when Judy Singer first coined this term, she wanted it to be non-exhaustive and to really be an inclusive terminology that's used to describe a group of conditions that are outside the neurotypical functioning. For the purpose of this presentation and kind of moving forward, I'm utilizing the version of a neurodivergent umbrella that comes from a neurodevelopmental perspective. So meaning these differences in the brain that an individual is either born with or that they develop early in life. And that these differences affect how the brain grows and functions and influences varying aspects of their thinking, learning, behavior, and social interactions as they move throughout the lifespan. So some of the conditions that are included under this specific neurodivergent umbrella are autism, ADHD, dyslexia, dyspraxia, Tourette's, and also noticing that I forgot on the slide, fetal alcohol as well is also included under this version of the neurodivergent umbrella. So for the purpose of this presentation, I'll be looking specifically at ADHD and autism. The reason for looking at both of these conditions in particular is that there's a variety of different factors where they overlap and where they are quite similar, but then there's also some areas in where they really stand out and where they have some specific differences. Some of the things that they have in common is really some of the differences with regards to information processing, sensory experiences, social interactions, and many individuals, I guess, to highlight, much like myself, I guess I don't need to highlight it because I've already mentioned, can have both autism and ADHD. This is something that changed in the most recent adaptation to the DSM. Prior to that, individuals who were diagnosed with either ADHD or autism could not be diagnosed with both. But luckily, the most recent edition has included that someone can be diagnosed with both, and that really recognizes the unique experiences of individuals who have both ADHD and autism. A funny way, not to, I guess, try to lighten the mood, a funny way to think about how ADHD and autism can connect or someone can be experiencing both is a way that I had seen it in, I think it was in a TikTok, but basically it was saying, that the show Big Bang Theory is that like Sheldon Cooper is the stereotypical definition of autism, whereas Penny is the stereotypical definition of ADHD, and that individuals who live with both are kind of both of those individuals put together. So I can't hear everybody laughing. If we were in person, maybe we'd all be laughing about it. But I like that representation because it's two very different people and two very different experiences, but they can be combined. And that experience of being an individual that's kind of living with both of those. With regards to ADHD, so this is characterized by a consistent pattern of inattention, hyperactivity, and impulsivity. And what ends up happening is there's impacts to an individual's executive functioning. In particular, some of the things that are highlighted is difficulties or differences with time management and organization, and self-regulation. Whereas with autism, it is a neurodevelopmental condition that affects social communication, interaction, repetitive behaviors, and individuals may also experience unique strengths, passions, but also some sensory sensitivities and differences as well. I just have two slides, one for ADHD and one for autism, just to highlight a little bit or to provide a little bit more information about each condition. So the most recent change to the DSM combined what was previously ADHD and ADD under the intention hyperactivity umbrella. So it was coming up with 3 separate classifications. So what you can see here in this diagram is the diagnostic, I wouldn't say the diagnostic criteria, but basically the stereotypical or the most common representations of the 3 different types. So we have a predominantly inattentive ADHD. So that looks at lack of focus, disorganization, difficulty following directions, distractibility, forgetfulness. And then in the middle, we have the combined type, but then on the other, we have the predominantly hyperactive impulsive. So this is difficulty paying attention, interrupts people, always on the go, that excessive activity, impatient, the fidgeting. Also something, I guess, that's more predominant in the research and things that people are starting to look at is the gender differences with ADHD. So as we know, the more classical representation or the stereotypical representation would really be that hyperactive impulsive ADHD, which is predominantly diagnosed in males. Whereas now what we're seeing is that predominantly inattentive ADHD, which can be more represented in females. It's that internalizing of the ADHD. I myself am diagnosed with the combined type, so kind of a little bit of both. But just looking at the fact is that ADHD can look very different. I meant to kind of start with that is just because someone has a diagnosis of ADHD or a diagnosis of autism, it really doesn't give you a clear picture just by the diagnosis of what they're experiencing. It can be very individual. There's a quote that says, you know, if you've met one autistic individual, you've met one autistic individual. So recognizing that, you know, some of the examples that I'm giving are really speaking from my personal experience with ADHD and autism, but that people can experience it very differently. So where it comes to autism, as some people may know, people talk about autism spectrum disorder and how autism is on a spectrum. Using the terminology spectrum, people may think it's kind of a very linear understanding that someone would go, you know, you'll hear people say, you know, are you more autistic or less autistic? You know, maybe you're just a little bit autistic. You know, you're able to be a social worker. You can't be that autistic. You'll also hear terminology such as a high functioning autistic or a low functioning autistic, but really both of those are not representative of the autism spectrum. As you can see in this visual diagram, this is really what they're getting at, or what we're getting at when we talk about autism as a spectrum. It's these specific criteria or these specific categories, and then those are kind of the linear representation. So individuals can have, you know, deficits and difficulties in these areas, or they can have very, you know, strengths and what's the word I'm looking for? It can be very different. A great example for that would be empathy. When people think about autism, they kind of think of that show The Good Doctor, you know, that very cold presentation, that lack of really understanding somebody else's emotional standpoint, or that other person not really being able to empathize with people. Whereas myself, when it comes to empathy, I have, when it comes to empathy for me, I really I guess, have over empathy. I think it's referred to, the term has left me, again, it's almost past my bedtime, but it's that like psychosomatic empathy. So when I emphasize for somebody, I can really take on, I guess, what I assume may be what they feel. So like when I was in counseling, if someone was very upset, I could really feel their emotions. I could really feel their pain. So it's that almost that too much empathy as opposed to not enough. I could ramble about this forever, but as you can see, there's just a variety of different categories on the spectrum, and people vary, and it's very individual, what someone may experience. Just touching a little bit on substance use health, and substance use in general. When I look at, or when I'm talking about substance use, I really look at the most recent spectrum of substance use, which came out from Health Canada. So looking at ranging from non-use, so no use at all, and to ranging up to addiction. I'm not going to go into this one because there's a little bit more on the next slide. So for the purpose of looking at neurodivergence and substance use, looking at two specific categories, so addiction, but also high-risk substance use. So high-risk substance use is when we look at patterns of substance use that carry elevated risks or harm. So this individual may not be experiencing an addiction, which what we know is classified as a chronic relapsing brain disease, which is categorized by those compulsive drug seeking and using despite these harmful consequences, which can be experienced by neurodivergent individuals, but also looking at that high risk substance use that that carries people engaging in substance use, that they experience negative consequences as a result of that. So when I'm talking about substance use in that population, we're really looking at both addiction and high risk substance use. As I mentioned before, looking at the correlation between both from a biopsychosocial framework. So looking at the interplay between their biology, so their brain circuits, their genetics, also looking at the environmental impacts, and also the individual's life experience. So whether that's their experience in the home, in the community, their mental health, other physical health. So really looking at the person as a whole, really that holistic view. So just to highlight some of the current research findings, recognizing that neurodivergence and substance use is really something that's only more recently started to be looked at, or to be really questioned, or people are recognizing that correlation, recognizing it but not really sure what's happening, but recognizing that it's something we should probably be looking at. But some of the things that I've noticed or seen in the research that's available is that there is a strong correlation that's observed between neurodivergence and addiction. This strong correlation in particular is highly researched when it comes to ADHD in particular. And there is some mentioning of autism, but there is a strong correlation between ADHD and addiction, and a lot of the correlation or the overlap also recognizes the similar presentations in autism. The research shows that the risk is twice as high for high-risk substance use. So an individual who's neurodivergent is at least 2 times higher, or a higher likelihood to experience high-risk substance use than their neurotypical peers. Some of the groups in particular that are highlighted to have a higher risk would be those individuals in particular who have both autism and ADHD. Those are the individuals who experience both are seen to be at the highest risk. Also in the research, it highlights elevated use of nicotine, alcohol, and cannabis in particular. Those are the 3 substances that are highly correlated between or higher use seen in neurodivergent populations in particular. With ADHD, as I noted, that is a condition that's really, there's more research available as opposed to ADHD and autism. There's definitely a more leaning towards ADHD. And what the research shows is that 25% of patients with a substance use disorder who present without that are not already diagnosed meet the criteria for ADHD. I'd argue it's probably higher, but that's what the research says. And then those individuals who are diagnosed with ADHD, who aren't engaging in service have a high risk for substance use or dependence. And with regards to alcohol, it's 17 to 45%, and then other substances range from 9% to 30%. So recognizing that the research out there is limited and there isn't a whole lot available, but I'm pleasantly surprised or happy to see that even since the last time I did a bulk of the research for a similar presentation, there's been a lot more literature that's come out. One of the newest articles that I'm really excited about is looking at individuals who haven't already been diagnosed with autism and the high prevalence of autistic traits in individuals who are already seeking service for addiction, and how to provide those services in particular. I won't ramble on about that. But the research and what we see in the research, some of the gaps that are identified that really highlight why we're not seeing as much, or why we're not, why this area isn't being looked at as much. So some of those are ableism. So when it comes to ableism, that's that overarching discrimination based on neurological or physical abilities. This one more so when it comes to autism as opposed to ADHD. With autism, it was, I guess, not so much more recently, but in the past, autism was kind of viewed as individuals who were autistic couldn't experience addiction. It was like they were immune to it, almost in the belief that, they weren't able to experience addiction. They weren't able for a variety of different reasons, whether they, weren't going out and engaging in the community, or they just didn't have the capacity, but really an ableist view, providing or preventing that from being looked at, or even being seen as something that we should be looking at. Also, the stereotypes with regards to autistic individuals, which probably perpetuated that ableism, is that, individuals who are autistic are very rule-driven, rigid, and socially avoidant. Although that some of those may be true and may actually be protective factors or risk factors. I'll get into that in the next section, obviously. But really holding that as an overarching belief as opposed to something that's more individual. When we think that all autistic individuals are this way, we're not really going to be looking at, people aren't looking at addiction as a possible experience. Also, there's a very child-centered narrative when it comes to autism. A lot of the research that is available really focuses on a pediatric presentation, or there's really that view that autistic individuals never really grow up. I'm not sure about, other provinces, but here specifically in Newfoundland, that's even represented in the services that we offer. A variety of services are available for autistic individuals up until the age of 18. Once you're 18, then you kind of age out of the service. So it's that view of autism as really a pediatric diagnosis or a pediatric condition, when not looking at the adult experience. The demographic bias. So as well, there is some autistic representation in the research that's out there, but it's really looking at it from a correction standpoint, and from a male perspective. So there are some research available, but it's very, very limited. Also, stigma and avoidance is contributing to these, I guess, the categories above. This became very prevalent to me when I was engaging in a research project as an individual with lived experience. I continually tried to bring up substance use and mental health to see if that was something other people wanted to talk about, but I noted that my question was consistently being avoided. So recognizing that there's a lot of stigma associated with substance use, so sometimes people don't really want to explore that. So just highlighting that can also be at play as well. So just looking at risk and resilience, so looking at those factors that could increase the likelihood that somebody may experience issues with substance use, but also those factors that could decrease the likelihood or be further supported to decrease the likelihood or support somebody in their recovery or making changes to their substance use. Again, before I go into it, highlighting that some of them more so the ones that aren't necessarily biological, can be very individual. Some of the risk factors or protective factors that I highlight could be a risk factor for somebody or a protective factor for somebody else. So just highlighting that it's very individual, but I'm just giving kind of a broad overview or a broad understanding, but recognizing that it could be very different from an individual perspective. The reason for looking at it from a risk and resilience or a risk and protective factor lens is that we really don't know the specific correlation between neurodivergence and substance use. It's kind of something that we know is there, but research hasn't been able to kind of pin down in particular. So by looking at the risk and protective factors, looking at a variety of different factors that are probably interplaying or having some impact on the correlation that we're seeing or that's occurring. So from a biological perspective, we can see that there's an underlying predisposition. So these neurological factors that are increasing the vulnerability in neurodivergent individuals, increasing the likelihood that they will experience some level of issue with related to substance use or addiction. One of the main ones that's at play is the reward system dysregulation. Essentially, what's happening is neurodivergent individuals have that altered sensitivity to reward and reinforcement. So that's only further reinforcing issues or difficulties with related to substance use. A lot of the literature will say, you know, neurodivergence is leading to addiction or leading to substance use, and then that substance use is feeding back into the neurodivergence. So it's kind of that increased connection and that predisposition, but also when they actually experience addiction, it can be that much more difficult to provide services or difficult to kind of like make changes with regards to their substance use. There's also a variety of different genetic connections. I'll just highlight a few of them, recognizing that I'm not a geneticist, so I'll probably not be explaining them properly, but the ones that are highlighted in the literature is the NLGN3, which based on the literature is an active in addiction hotspot region, and it's linking autism and substance use. There's also the CNTNAP4, which specifically is related to dopamine levels, and that can also increase the likelihood of having difficulties with regards to substance use. The easiest one for me to explain, which is probably also because it's something that's close to me and I can observe in my immediate family, is that this connection is supported in the research that shows us that individuals who are neurodivergent, their family members have a higher likelihood of experiencing issues with substance use or a substance use disorder. Also, with regards to the brain structure, there's some changes in the smaller frontal cortex and the cerebellum, which potentially influence or impact decision-making and impulse control, which I'll touch on a little bit in the other categories, but that interplay is increasing the likelihood. Also at play is neuroadaptation. And what we see with neurodivergent individuals is that they have a higher likelihood of developing a tolerance quicker, meaning that they, as their tolerance develops, they require more and more of a substance. So for neurodivergent individuals, the amount that they consume, depending on the substance, will increase at a higher rate, so that they're consuming more and more quicker than their neurotypical peers. The biological impact, so looking at the effects of substance use and those implications, this is a biological impact that I really saw. Well, I saw it in the research, but really I got to see at play in my practice as an addictions counselor. Wasn't something that I noticed in particular as I was seeing these clients, but really when I had that neurodivergent lens and could take a step back, I really was able to see how much that was impacting or kind of reinforcing substance use. So just chose two categories to highlight, both the pharmaceutical and the recreational use or non-prescribed medication. So for example, when we look at stimulants, there is that misconception or that myth that starting ADHD medication may increase the likelihood that someone will experience an addiction. We see this a lot in our younger youth population. You know, parents are not wanting to start their child on ADHD medication because they think that this may lead to addiction later in life or some dependence on substance use. However, the literature actually says the opposite, that starting ADHD medication can reduce the likelihood that someone will develop an issue with substances later in life. Also, I was able to see this at play in some of the adult clients that I was servicing as an addictions counselor. The last couple of months in my practice before I left clinical practice, I had clients who I'd been seeing on and off for, a year or two, and they were really struggling to maintain or obtain the level of recovery that they were looking for. Once they had a formal diagnosis of ADHD and started ADHD medications, two individuals in particular really started to flourish in their recovery. They highlighted that they were able to think properly, that they were better able to make decisions, they felt more relaxed, their anxiety was lower. And for them, being able to take ADHD medication really impact their ability to stop using their substance of choice, which for both of them is depressants, which I'll mention now in a second, and how that can be at play. Also with stimulants, I kind of preface it here as recreational, but looking at really stimulants such as caffeine and cocaine, which are the two that I'd like to highlight. Caffeine in particular was something that came up when I was actually being assessed for ADHD. And the psychologist kind of said to me, like, do you drink a lot of coffee? And I was like, oh, I love coffee. I drink so much coffee. It's literally my personality. People who know me kind of relate me to coffee. But what I said to her is coffee never gives me energy. Coffee is actually what helps me relax. It helps me calm down. I could have a latte right now and still go to sleep. On the flip side, seeing clients who are using cocaine, it was like, cocaine for me isn't a party drug. Cocaine is something that I use to help me function, to help me get my chores done, to help me get things done around the house, to help me focus. So what's happening there is the stimulant use for these neurodivergent individuals, myself included, was reinforcing that continuous use of stimulants because it was actually having a positive effect. But a different effect than people who are not neurodivergent. These stimulants were actually helping us to relax, or helping us to get things done, or to think more clearly. So for that reason, it can be reinforcing that use because it's really seeing it as beneficial, which can be really challenging with regards to caffeine, but also with cocaine as well. Whereas with depressants, with regards to pharmaceuticals, they can be prescribed for a variety of different reasons. One in particular is neurodivergent individuals may experience tics or some like uncontrollable movements. Depressants can be prescribed to help regulate or to help reduce those experiences or to help make them more manageable. But from a recreational perspective, alcohol in particular and other depressants can really help induce those feelings of relaxation in addition to other symptomatic relief. So again, reinforcing that continuous use. One of the ones in particular, one of the reasons or the associations is alcohol and its ability to numb that overactive sensory response. For example, for myself, I don't really like socializing in large groups, but I recognize, much like for other people, alcohol kind of took that edge off. Not until I was diagnosed did I realize the edge that it was taking off was actually that the sensory responses. It was taking away how overwhelming the bright lights were and the sounds were and all of the different senses that were being kind of lighting up or lighting on fire when I was in those scenarios. So what ends up happening is for neurodivergent individuals, they see that alcohol or other depressants are really helpful, and again, reinforcing that continued use because of the additional positive effects in addition to those that are seen by their neurotypical peers. Also from a social environmental impact, so highlighting some factors that may be a risk factor and some that may be a protective factor. Isolation being a risk factor, as we know, with regards to substance use, isolation can really lead to increased use. It can also lead to riskier outcomes or more negative outcomes with regards to substance use. So if people are using in isolation, they may not be, people may not be recognizing the negative outcomes, or someone may not be receiving the appropriate support because they're in isolation and not around their peers or around other people. Trauma in particular, this could be a whole presentation, but there is a strong correlation and link between the experience of trauma in the neurodivergent population, and that's for a variety of different factors. It can be seen as a precipitating factor, so increase in the likelihood, but also making trauma or the experience of coping with trauma that much more challenging. So we know the connection between trauma and substance use is that individuals who have experienced trauma are at a higher likelihood of developing issues with substance use. That may be related to, finally finding a way to cope, so a maladaptive way of coping. But there is that connection between trauma and neurodivergence, and then again, that connection between trauma and substance use and substance use disorder. Community disconnect, so not really having that connection to community or positive relationships can increase the likelihood that someone will engage in substance use or high-risk substance use. Feelings of insecurity, so low self-esteem, self-worth can increase the likelihood. Social discomfort and anxiety, so again, kind of relating to the previous slide, using substances to cope with anxiety, where neurodivergent individuals have a higher likelihood to experience discomfort and anxiety, they all have a higher likelihood of using substances as a result of that. From a protective perspective, isolation can also be protective in the fact that if people are in isolation, they may not be exposed to different substance use or to different things with regards to substance use. So you're not in that community or in that environment, you may not start using it because you're not exposed to it. Also, neurodivergent individuals, depending on their experience, may have intensive support. So they may have people in their life, whether that's additional clinician support or medical support or, informal supports, that additional support can really help either to prevent them from developing a substance use issue or a substance use disorder, or may help them in achieving recovery or to making changes because of that support. Rule adherence, so I kind of mentioned that when we talk about stereotypes in particular. Rule adherence is seen as preventing people from engaging in substance use because it's seen as wrong or inappropriate or something that you shouldn't be doing. A prime example of that is me in high school. I was that person going around and telling people that, cannabis was illegal and they shouldn't be doing that because they're hurting their body and all of the different things. I'm not sure how I survived high school by doing that, but somehow I did. But I wasn't saying any of those things about alcohol. But for me, I really had that strong belief that people should be not be engaging in things that were illegal because of the harms associated with that. So because of that, as well, what is shown in the research is that autistic individuals have a higher likelihood of engaging in alcohol use because it is legal. I'm curious to see how the literature or the research may change now that we're seeing shifts in the legalization of cannabis in particular. But yeah, so that rule adherence is not engaging in behaviors they're not supposed to, whether that's legal or whether that's imposed by like a parental figure. Attention to detail, creativity, and a unique perspective, those are really highlighted in the literature as being positive when someone is seeking additional support. So engaging in clinical counseling or trying to engage in other activities that may reduce their substance use or increase the likelihood that they will stop using. It's that attention to detail and that creativity and the unique perspectives that really have a positive impact on their recovery. I'm just checking the time, so I'll try to provide a little less detail so we can get through it. Diagnosis, one of the main things to highlight here is kind of highlighted in the quote there at the top. The failure to identify and understand neurodivergence may contribute to a worsening of their symptoms or an increase in concerns related to substance use or gambling. So what that's getting at is when people don't know what they're experiencing, it can prevent them from receiving appropriate care. Receiving a diagnosis of ADHD or autism, there can be a lot of different barriers associated. Privately, so there's a financial cost. Also, some professionals may not prescribe or prescribe ADHD meds or even send someone for an assessment if they don't feel like that person fits that classical definition. So when we have that really rigid view of ADHD and autism and we're not seeking diagnosis for people or even considering that it could be possible, we're really missing being able to provide that person with the adequate support and care that they could receive. Also, receiving a diagnosis can very much be a risk factor because it can result in exclusion from engaging in certain services. For example, here in our province in particular, some mental health or addiction services have autism in particular, not so much ADHD, but autism as an exclusionary criteria, recognizing or those services saying that they're not able to provide service. So really that goes against the neurodiversity perspective or the neurodivergent perspective is not really adapting or changing our services to be able to support people. And through not adapting, we're just excluding them from it altogether. Another category, kind of hard to come up with a specific title for this one because it's so vast and a lot of differences for ADHD and autism, but just highlighting some of the most common ones. So these are the characteristic and observable behaviors. So those, I guess, characteristics that are kind of associated with both ADHD and autism. Executive functioning being a large one with a bunch of different things that fall underneath it, but executive functioning being seen as a risk factor. So impulsivity and decision-making, people may have a lot higher likelihood of engaging in substance use without really making an informed decision or an empowered decision. Emotional regulation. So when we have difficulty regulating our emotions, we may be more likely to engage in substance use to help regulate our emotions. Issues with self-esteem can increase the likelihood. An interesting one with attention and focus, that can also that can be that people, struggle to pay attention or struggle to focus, whether that's in a clinical setting or just in day-to-day. So that can impact their ability to engage in service. But a really interesting quote that I have here from the literature looks at someone having high attention and high focus and how that can lead to difficulties with substance use. So it says, it seems that the same regions that give me an intense curiosity, obsessive focus, and ability to learn and memorize quickly also made me vulnerable to discovering potential bad habits and then rapidly getting locked into them. So that's that attention focus, but also that habitual behavior. Another quote in the literature talked about an autistic individual who became really intrigued by like the different strains of cannabis and kind of saw that as a really interesting area of research. So they started to engage in higher levels of cannabis use because they were trying to see the differences and the way they impacted them differently. So just showing that attention and focus could also be that hyper attention and that hyper focus can increase the likelihood. Sensory, I've already touched on. It can be, using substances to cope with that. And habitual behaviors, again, specifically in autistic individuals, it's that habitual kind of having that same pattern and doing things very similarly. If substance use somehow integrates itself into that pattern or the habitual nature, it can be more difficult to kind of break that habit and break that pattern. Masking is probably a term people have heard about. I've seen it a lot in more recently in some of the literature, but really what masking is getting at in relation to the neurodivergent population is that neurodivergent individuals, to fit into a neurotypical world, are having to conceal who they truly are. So concealing, their emotions and their characteristics, really behaving in a way that fits with that societal norm. So really going about your way to be or to present as neurotypical. I myself didn't really realize how much of an impact that was having on me until I tried to kind of be who I am, or to stop masking. Masking can be incredibly exhausting. It's going through your day and not just being present, but trying to change who you are so that you can fit into the societal norm, or to be able to kind of upkeep what other people are doing. It can lead to, persistent overthinking, persistent observation, persistent changes in behavior. And when we do that, and when we're so exhausted from it and emotionally drained, that can increase the likelihood of engaging in substance use to cope with that. Also, substance use can help eliminate the pressure or the feeling or the need to mask, so using it to cope with that. Also the sensory relief, also the social facilitation. One of the things to highlight when it comes to masking, especially when you're working with clients that may highlight that they are masking, is that they're having challenges in different situations. Meaning that people who mask may have a specific mask that they use in certain categories, or that they're familiar with using. They have a mask they wear at work, they have a mask they wear with their parents, with their friends. And when I say they have a mask, specifically for myself, I had no idea that I was masking. Really until I started taking ADHD medication did it become really apparent to me what was happening. So that mask that's exhausting to them, they may not even realize that it's there. Also, to highlight that masking can really impact someone's ability to engage in clinical service. So when I would go to counseling myself, I was consistently masking in counseling. It's like I had this mask that I wore to engage in clinical services, so that I really wasn't able to be present and engage in service, because I was trying to present myself in a certain way to the clinicians that I was seeing. So I was constantly providing them with the answers that they wanted to hear, as opposed to the answers that I was really that were really true, or that I was really experiencing. So the impacts and the applications. One of the big things that can be seen for neurodivergent individuals is that they really experience a fragmented care. And what that means is that the services that they're availing of, or the services that they require, are really operating in silos. So speaking from, I guess, what's in the literature and what we're seeing more so in Newfoundland, so I know this might be very different in some other people's provinces, or the regions where they work, but the neurodevelopmental services, so services that are predominantly for neurodivergent individuals, operate in one silo, whereas psychiatric services and mental health services operate in another, and addictions operates in a very different one. And when there's not that collaboration between those sectors, the individual is not really getting that full level of care. It can also be seen, again, like I said, with that exclusionary criteria. It's kind of like, well, if you're being serviced by neurodevelopmental services, you're not being seen by psychiatric or addictions. And what that is that's not recognizing that people can very much have a neurodevelopmental condition, but also experience those other conditions as well. So when they're operating in silos, individuals aren't getting the full spectrum of their needs being met. Also, neurotypical services, or the services that we offer, are neurotypical in nature, meaning that, there's rigid rules and group settings. And for neurodivergent individuals, this can really not only not provide the appropriate care that they need, but can amplify their anxieties. A great example of this that was in the literature was talking about a woman who was going to an AA meeting. And she said, I couldn't even really engage in this group counseling because I was too busy thinking about how the guy across the way was staring at me, and how I should smile at him or how I shouldn't smile at him. So it's really highlighting that, like in a group setting for certain neurodivergent individuals, they may not be able to even think about their own experiences, that they're so actively trying to mask and trying to be aware of everybody else in the room that they're not able to really participate. Also, rigid rules about, missing appointments or not providing people with reminder appointments can be really difficult, when those things would be incredibly beneficial to neurodivergent individuals. Also, when people struggle with showing up to appointments or struggle in certain counseling settings, these can be perceived as being non-compliant or defiant. So as opposed to viewing them as something, as an issue that someone's experiencing, it's actually viewed as them not participating or being defiant, as opposed to something that's related to their neurodivergence. So the consequences of this, when we have a fragmented care, or when we're operating in silos, is that individuals are provided with a misdiagnosis. So obviously, when someone's not provided with the appropriate diagnosis, there can be challenges there. They could be provided with treatment that's not only not beneficial, but that could be detrimental. So when you don't have the proper diagnosis, you could be provided with an inappropriate treatment, which could have negative consequences. One of these in particular, in my clinical practice, I used to do a lot of DBT work. So what we're seeing now in the literature is that females in particular who've been diagnosed with borderline personality disorder are now, in some cases, being diagnosed with autism. However, as we know, or some people may know, a lot of the services that we provide for individuals diagnosed with borderline personality is DBT. Whereas DBT can be very challenging for autistic individuals and may not be appropriate. There is, from a neurodivergent perspective or neurodiversity, there is adaptation. So there's actually a fully different or a completely different approach to DBT for individuals who are neurodivergent. So yeah, could lead to mistreatment and then increased vulnerability when we're not looking at individuals who are receiving neurodevelopmental services, when we're not even considering, I guess, that neurodivergent individuals may experience substance use disorder or substance use issues. We're not assessing them. We're not determining whether or not they may require additional support. So they're at that increased vulnerability for not receiving the appropriate care. So what can we do from a primary or from a prevention and treatment perspective? So looking at a prevention framework very briefly. So, primary is when we're looking at focusing on general measures to prevent the onset of substance use. So what we're doing before anyone even experiences those issues. So I'll just talk briefly on that. Whereas secondary prevention specifically targets individuals for early identification of possible issues and then implementing intervention, whereas tertiary prevention is when individuals are already experiencing substance use disorder or issues with substance use, and how we can modify the treatment to ensure that it appropriately meets their needs. So from a primary perspective, so that proactive approach, we're looking at strategies that prevent the onset of substance use or delay the onset or halt the progression. Examples of this could be educating the public, families, and neurodivergent individuals about the risk and consequences of substance use, specifically tailoring those to their unique experience and vulnerabilities. So examples of that could be hosting awareness campaigns that highlight the potential for substance use or misuse for those who have ADHD or autism or other neurodivergent conditions, and emphasizing how these substances might interact with their neural pathways differently. So really increasing that education from a very broad perspective across populations. So not just specifically to neurodivergent individuals, but society as a whole. Whereas with secondary, looking at that early identification, so it's targeting our interventions specifically for individuals who are showing early signs of substance use, but haven't yet developed an addiction. So this would include, or a substance use disorder. This could include rapid screening and brief intervention that's specifically tailored to neurodivergent experiences, and an emphasis on understanding the triggers or reasons behind substance use. An example of this, specifically with younger populations, would be developing a toolkit for teachers or caregivers to really be able to identify those early signs that someone may be exhibiting that may lead to issues with substance use, so that they're better able to provide guidance or immediate interventions. just providing, oh, it's not going to let me show it to you guys, but this is just an example of it. So a project that I've collaborated with here in our province is just looking at an education strategy for teachers. But one of the things that we've included in that, and I have done up an information package, but for everybody to get more information in these areas, but it's an information package for teachers in particular on how to better support neurodivergent individuals in the classroom. And by better supporting neurodivergent individuals in the classroom, it's really supporting those protective factors and negating those risk factors. Whereas from a tertiary perspective, it's minimizing the impact of individuals who are already experiencing issues with substance use and improving their outcomes. So that would be strategies to reduce the more serious effects, assisting in accommodations and rehabilitation and recovery. So it's really modifying the way that we provide service. So stepping away from those neurotypical ideals and providing a neuroaffirming or a neurodiverse perspective. So what this looks like is personalized therapy and treatment, plans that respect and understand the unique needs of neurodivergent individuals. And I'll touch on this in the next slide. It's really focusing on emphasis on these coexisting conditions and not separating them and treating them differently, but treating them together. An example of this is offering dual diagnosis treatment programs that address both neurodivergent conditions and substance use disorders, ensuring a holistic approach to recovery. Obviously, I know that there is a lot of services out there that look at that dual diagnosis or treating addiction and other conditions at the same time. However, a lot of the research out there that looks at these dual diagnoses are looking specifically at mental illnesses in particular and not necessarily neurodivergent conditions. So there is limited research there, but we can take a lot of similarities from that dual diagnosis approach for mental illness and apply it in the situation with some slight differences. So what this approach looks at is that having a dual diagnosis, so being neurodivergent and also having issues with substance use, may complicate your diagnosis, the treatment, but also the prognosis. One of the things that it highlights as well is that comorbidity is the rule and not the exception. So recognizing that professionals who work in the area of addiction should be provided with adequate education and support for treating neurodivergent individuals, recognizing that the prevalence is there and that the likelihood that they will see individuals with both is quite high and not the exception to the rule. Care needs are identified through collaboration with the client as opposed to kind of coming with the approach already pre-developed, is working with them to determine their needs. Needs are addressed simultaneously at the same time. One of the main reasons for doing that is that without addressing both at the same time, when you kind of stop using substances, that can exacerbate your things associated with neurodivergence and then vice versa. So when you address them at the same time, it can kind of have that synergistic, like positive effect on both. Neurodivergent clients can present with distinct care needs. There's a bunch that are highlighted, and I've highlighted them in some of the resources I've put together, but some in particular are highlighted as building self-esteem or working on self-esteem, encouraging internal motivation, identifying specific triggers that may be experienced by neurodivergent individuals, learning how to cope and manage impulses, modifying destructive behaviors that promote substance use, providing additional education to partners and family members about not only substance use, but also neurodivergence. That's just some in particular. Also, what falls in line with that is the philosophy of neurodivergent informed therapy or neuroaffirming therapy. One of the ways that I explain this to people, which makes it, I think, a little bit easier to wrap your head around or to understand, is it's very similar to a trauma-informed approach. So meaning that, when we apply a trauma-informed approach, we're really thinking about the connection that trauma has, and how someone's behaviors that they present with may be directly related to trauma, as opposed to, again, kind of going back to the previous slides, a way of being defiant or a way of not engaging appropriately. So it's kind of looking at how someone's individual experience can impact their engagement in counseling or their engagement in service. It looks at accommodation, so changing things as opposed to looking to cure someone. It's kind of changing their environment as opposed to changing them. Also, neuroaffirming therapy really looks at co-design with clients. So working with the client to help identify their unique challenges and their goals and what they would like to see differently, and how you can continually work with them to adapt your approach. Again, in line with a trauma-informed approach, a neuroaffirmed approach is seen as a universal approach, or a universal precaution, meaning that using a neurodivergent or neuroaffirming therapy is beneficial to all individuals, not just individuals who are neurodivergent. And this can be really beneficial to use because a lot of people may not have an appropriate diagnosis, or they may be querying a diagnosis. So really taking this philosophy and this perspective can be helpful for everyone. And I'm by no means capturing everything about it, just touching on it briefly. Some other important considerations that I like to highlight when providing services to neurodivergent individuals. Some I've already touched on. There's a lot of literature to support that individuals who are neurodivergent benefit more from individual support as opposed to group counseling. I myself recognize as a former clinician the enormous benefit that people can get from engaging in group support and group counseling. It's, that having your experiences validated and learning from other people, that can be really challenging for neurodivergent individuals when they're not able to really have that internal process while they're in there. What also can be really different or difficult, both when attending group services or when attending individual services, is what's called double empathy. So what that's getting at is communication styles. So what it is when you have a neurotypical person and a neurodivergent individual, it can be really difficult to understand that other person's communication style or what they're trying to communicate. So what the literature says is when working with individuals who may be neurodivergent, it's really being clear and concise in your communication, being very direct, and things that we already do in clinical settings. So practicing active listening and then validation as well. So it's important, obviously, to obtain more information on neuroaffirming practice because this is very, very, very brief. Sensory conscious space. A good example of that is, as a neurodivergent individual, I really hate overhead lighting. That's a very minimal example, but when I didn't have clients in my office, I would never have the overhead light on. I always had small lamps, and people would joke and say I was trying to set the mood for clients. So when clients came in, I'd turn on my light automatically. And it wasn't until I was diagnosed myself that, as opposed to just turning on the overhead light when clients were coming, I would ask clients, would you prefer to have the overhead light on, or do you prefer the lamp? And I never had anyone who said overhead lighting or overhead lighting. So it's just thinking of the sensory in your space. Do you have really thin walls between you and your coworker? Maybe your clients are going to be distracted by that. Scales can be really helpful for individuals who are neurodivergent. It can be easier for them to pick out specific scales. And the other one as well is because of the processing, what's the word I'm looking for? What I'm trying to say is neurodivergent individuals can really benefit by taking notes in sessions or being provided with notes afterwards. So what I would do for neurodivergent individuals in particular is provide them with the notes that I took during session or an overview. It can just be helpful for them to go back and have a look over. I'm recognizing that we only have 15 minutes, so I've covered, that's the bulk of it, but that is everything really. So I'll stop sharing, and I'm sure there's probably lots of questions, or I hope there is, and I hope I've provided lots, so there's not too many.
Provided lots and lots. I'm wondering, we don't want to cut you off if you had a sort of wrap up slide or conclusion that you need to.
I did. Thank you for that. I should put it back up. Hey, just one second. So just to kind of provide an overview. So this was just kind of an overview of everything that I kind of mentioned. One of the the biggest things, I guess, would be the moving forward. So what can people do, after attending this presentation, or what would be the things to think about moving forward, is really increasing our education. If people don't know what they don't know, I myself had no idea that, or how to best serve neurodivergent individuals until it was really put right in front of me. I really had to learn about it because it was something I was experiencing. Also collaborating with individuals who are neurodivergent, and also collaborating between services. And then also trying to change our services so there's not really a one size fits all, but really meeting the needs of clients in particular. So yeah, that's really the overview of it, I guess.
That's really great. Thank you. I know you've given me a lot to think about, and I think not so many questions because people are so busy thinking and digesting what you've shared. So please put your questions in the chat, or as I said, feel free to raise your hand and ask your question. A terminology question, Megan. Is it a person with neurodivergence, a neurodivergent person? And then I guess I'm going to add to that because I feel a little bit hesitant in that even that is kind of grouping people with different conditions.
Yep.
In the way that I understand is really intended to be inclusive and supportive, but is it problematic, I guess? So maybe part one, neurodivergence, yeah.
And that's a great question because it's actually the slide I skipped over. So when we talk about neurodivergent person is acceptable, but so is a person with neurodivergence. I guess neurodivergent is the one most used as to represent an individual. Totally get what you're saying, being like, lumping people in together can really impact the individual experience. But what can also be seen by people is that identity, and that identification is that, like, I am neurodivergent and this is the community that I come from. So people can really, and that's kind of part of the neurodiversity movement, is that identification and that community. So I'm sure some people might not want to be considered neurodivergent. It might be, no, I have ADHD, or no, I'm autistic, but I guess there's nothing out there to not support using that. The other slide that I was going to use was, when I was first diagnosed as autistic, or diagnosed with autism, I didn't even really know what was accepted. Did I say I was an autistic person? Did I say I was a person with autism? Specifically, when we look at autism, what seems to be the most preferred, and is for me, is that identity as I'm autistic. And so again, it's not a person with autism, it's the autistic identity. So just some people struggle with that one. It's like, do I say someone has autism or they're autistic? That's kind of the most accepted in the community now, is that someone is autistic, not someone with autism. Yeah.
Which feels a bit counterintuitive because we've spent so long working on person first language. The person with diabetes, as Katie put in the chat, the person with a substance use disorder, or an addiction even, although we use, right, not the addict. So yeah, I do find it curious. And I guess maybe it speaks to your reference point to really trying to support and embrace this as being part of an entire spectrum of neurological.
Yeah, and to use Katie's example, like when we look at diabetes, that's a disease that we can help modify with medication, or, we can't necessarily cure somebody, but it's like, it's seen as a deficit or a negativity, whereas kind of taking back or owning or saying that you're autistic is not seeing it as a negative thing. How I've explained it to other coworkers, especially who work in addictions, it's like, clients who may come from, the AA community, or other self-help. It's like, hi, my name is Megan and I'm an alcoholic. I would never challenge that client to be like, no, you really shouldn't call yourself an alcoholic. You're a person with a substance use disorder, or you're a person with an alcohol use disorder. That person saying that they're an alcoholic may really explain things for them, and it may, it's part of that community that they come from. So it's also very individual. I would never challenge somebody, but also recognizing that if someone called someone an alcoholic, I'd probably check them and talk to them a little bit about stigma. So yeah.
Question, why couldn't you have both ADHD and autism, or autism spectrum, in previous DSM editions?
That I'm not I won't lie and try to act like I know that the ins and outs of that, is because I have looked into it. But I guess the previous belief is that it was more looking at them and how they differ, and that certain people couldn't experience both at the same time. Whereas now they've really looked at how people can have both. Like some people will have ADHD and they're like, no, it's really autism. It's not ADHD at all. But then there's certain things that are associated with ADHD that aren't in autism. So I think what's happened is it's not so much that there was things that were preventing us. It was that limited knowledge of ADHD and autism. So wasn't really seeing that they could occur at the same time. Because like I myself know that I'm very different from some friends that I know that have just ADHD, or some friends that I know that are just autistic, is that it's a really unique experience. So I think it's something they're just really starting to explore, but I don't know specifically why. I think it was just the belief that you couldn't have both at the same time.
A narrower understanding, I guess, of what it was. And I am thinking about the analogy you made to providing trauma-informed care. I was thinking about that before you said it, and how relevant it is, because we think about universal precautions when trauma is so prevalent. So I appreciate that we can provide some general kind of accommodations around the sensory environment and things like that. But again, extending the analogy, I think many of us feel like we can take a trauma-informed approach, but we're not trauma therapists. So in a world where we're trying to do a lot of things, and I think many of us on the call would be clinicians like nurses, NPs, physicians. How do we help to bridge that from just being neurodivergent aware and recognizing what we can do when there's such a shortage of services? And I guess I even think about diagnostic services. So, we're seeing people coming in who may well not have a diagnosis. We might be starting to kind of wonder about it. Then what? How do we bring it up and proceed?
And that is a great question, because I even see that here, or when I was working more in a clinical practice, is like coworkers were coming to me with questions, how can I best support this individual? And then it was like, well, when I'm leaving, who's going to help them? But again, I never went and did a specific program to be more, or to increase my ability to provide service. What I say to people, because I think that's a fantastic analogy, it's like, I'm not a trauma therapist, but I can be trauma informed, is when we're helping provide services to individuals who may be neurodivergent, it's if we look at not necessarily the condition or the diagnosis, but the experiences that they're having, and look at it that way, and focusing on, someone who's autistic may really struggle with certain decision-making skills, whereas you might have the skills to help people with that, but not necessarily an autistic individual. So it's kind of breaking it down and making it more so about the issue they're presenting with, as opposed to the diagnosis, if that makes sense. But I do think we do require support that is more specific, and I don't think that that's there. And I think that speaks to the belief, or what we've seen in clinical practice, is that autism is really looked at as like a childhood illness. Like I feel like we've been really stunted in our ability to provide support to autistic individuals, because it's more seen as like a childhood illness. When it comes to diagnosis, one of the things that I've done as a clinician is really help clients advocate on their own behalf. So it's like helping them to self-advocate. Maybe it's with their GP, and that can be helpful for the GP as well, as like highlighting the things in particular that they're seeing, or that might be indicative of a diagnosis. So I know that doesn't really give a great answer, but it's just some of the things you can do, is just being more informed. But then there is a massive gap in services that are specialized in particular.
So one of the things I think about as a tool that's very often used, again, in the adult population with substance use, is motivational interviewing. And I'm wondering if that might not be such an effective tool in this setting.
That is something that's debated in the research, is that motivational interviewing isn't beneficial. There's a lot of research are a lot of different things that are highlighted in particular. So it's motivational interviewing, and there is an adaptation, and I'll make sure to include that in the resources. I don't think that's there, the MI adaptation, and also CBT. So as we know, CBT can be a really common approach in clinical practice. There's a lot of literature to support that CBT isn't beneficial for autistic individuals in particular, because of the mental processing, which can be hard. Because it was funny, because I used to see that as a clinician, I saw how beneficial it was for other people. I could help clients, but then when I would go to therapy myself, I'm like, this is garbage. This isn't very helpful at all. So that is true, right? Sometimes the approaches might not be helpful.
There's a question, I'm going to come back to the previous one, about whether you're aware of any literature about ACT, acceptance and commitment therapy. So CBT, DBT.
I haven't seen that, but just on my knowledge of acceptance and commitment therapy, I think that might actually be really helpful for some people, is that especially for autistic people, I think that would be an interesting approach. But I'll look into that, and maybe I can include that in the resources as well. But that hasn't been one that's highlighted as not helpful. It's more so DBT, CBT, and sometimes MI. That one's kind of on the questionable.
And the group setting, which you highlighted, and that's so critical because we do so much work in groups now. Previous question, and I know you're going to share resources. You gave a list of areas to focus on in therapy, starting with building self-esteem and encouraging motivation. Could you quickly run through that list and any particular resources you would recommend?
Yeah, so I've done up a resource list so that will be more helpful, I guess, to highlight that. Some of the ones, I guess, some of the topics that the literature supports as being helpful would be, I'm just going to bring up that list. So it's self-esteem, focusing and working on internal motivation. Where's that too? I just want to make sure I don't miss any. Focusing on triggers. So what that's really getting at is acknowledging what's going on with that trigger. So just recognizing that something is a trigger might not be helpful, but recognizing in particular that the trigger is actually the sensory overwhelm. It might not be that you're like, for an example, it's not that you're like downtown in a bar. It might be that the lighting in the bar. So it's really like focusing and more in depth on triggers. Focusing on impulses, which, is common in addictions counseling, but looking at it from a different perspective. Looking at destructive thoughts and behaviors. And then the other one is really, again, what we would do in an addiction setting is, providing additional information to family members. So not just information and support with regards to substance use, but also surrounding the neurodivergent conditions as well. So like more education on what is ADHD and what they're experiencing, and what is the autism spectrum, or what is ASD. Like even, for example, my own parents, when I was diagnosed, they had like a lot of guilt and shame because they felt like they didn't provide me with the adequate supports, like that they missed something or that there's something they could do. So providing that additional support to their support network can be really helpful as well, or even encouraging them to get additional support.
Yeah, it's a great point. I have one more question. I know that you're not a prescriber, and I'm wondering if there's any sort of high-level messaging around, other than, treat ADHD with medication when appropriate. We know that that can be helpful. And you've highlighted that can also bring up other symptoms we need to pay attention to. But in terms of any other medication-based approaches for alcohol use disorder, which obviously we see a lot of with the neurodivergent spectrum, opioid use disorder, are there any things for us to learn about medications or specific substance connections?
Not that I know about. I think the research supports using like the same medications as you would for someone who's not neurodivergent. Like it would have, there's no like research that says it's not helpful or it's not beneficial. I guess the number one thing that they highlight though is with ADHD, when you start the medication, is that it can bring out autistic traits, but that's more with the masking. And then there also is some literature about that neuroadaptation. So individuals who are neurodivergent may have differences with their tolerance levels or their requirement or their ability to absorb medication. So they may require like a higher dose of medication, or their tolerance may build quicker. I don't know anything specific, but like if you look at ODT treatment, like maybe they might need to start at a higher dose and maybe they might not titrate down as quickly. So yeah, it's more about like the tolerance and how that may be a bit different, and their ability to absorb medications might be different.
Mhm. Yeah, or I guess not necessarily the absorption around pharmacokinetics, but the sort of brain response in terms of,
Yeah.
as you said, what's calming, what's stimulating, how much people need. And then certainly I've seen some interesting dynamics around stimulants and then benzodiazepines and alcohol and caffeine and, all of those kinds of things together. Thank you. We are at 8:32. That was fabulous, very informative. I think everyone will be really happy to see that resource list. And you did a great job of framing some of the questions and making it general enough that I think we can all sort of take this away and think about some of the people that we're working with and begin to apply. So thank you so much. Everyone, please remember that our next dialogue series, which is typically a follow-up on the webinar, so opportunities maybe to think about how can we begin to apply this in our practices. I guess I'm thinking especially in RAM settings where our interactions may be relatively short-term, but some of us work in other settings too. I saw Karen Leslie, so thinking about the youth setting, really interesting. So that's Tuesday, June 4th at 8 a.m. And then our next evening webinar is going to be June the 19th, I think, with Carol Hopkins. Thank you, everyone. Please complete your evaluations. And thank you again, Megan.